Hello, welcome to you all. I'm Roy Noble, and it's a great privilege and pleasure to be here as a Bevan Commissioner on an auspicious occasion. Rosio cynnes I chi gyd, nawr ni di dod fel casgliad ar ddwrnod arbennig gyda'n gilydd. It's the showcase for the Adopt and Spread program, supporting adoption sites as they take Bevan exemplar innovations and innovators right across Wales. I've always been intrigued with innovators indeed. Where does the idea come from? Does it build slowly in the mind, or does it gradually, catch you unawares and a flash of inspiration in the middle of the night where you have to write it down on a paper before it actually goes? Now, when I was a young boy of 11, there were certain methods to help your innovation and to help your persistence, which is also something you need when you get an idea. And it came at the age of 11 when we tried the exam for the grammar school. And if you didn't show, a full 100% capability in the class, your parents got worried that you might not get to the grammar school. And they would try and add incentive, like, if you pass, you'll get a bike. Or if you go to the grammar school, the uniform is brown. If you fail to go to the secondary modern, where the uniform is navy blue. You've never looked nice in navy. But the great threat was that if you had ability and you were not firing on all cylinders, there was something that could be done. You could be taken to a specialist lady who specialized in the old medicines of the deep far country in Carmarthenshire. And she would do it to you. You would be taken to her parlor, and she would have three things in there: a bowl of hot water, a knife, and a towel. And she would cut your ear behind the ear until it bled. The belief was that once the blood flowed and was released, all your innovative capabilities were released as well, and all your intelligence was released as well. And you could become an Einstein overnight. And if you were very thick and tough, she'd do both sides for you. Actually, we never talked about it in case the police found out. But if you go to my village now, have a look around for boys my age who can't keep their glasses on. They probably have had it done. Now then, the Bevan Commission, if we think about that, the Bevan Commission has been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators indeed. 15 of the Bevan exemplar innovators were selected to share their innovations with a new site, and over 50 new adoption sites have taken on one of those great innovations forward. Over 150 people have been involved in the adoptions and spread of innovations right across Wales as well. Now, let's not forget, this work has taken place during COVID-19, and the participants have had to work exceptionally hard, over and above what they normally do. This is the extra mile. And it's, to make that impact and to ensure that we all learn from the program. In the mechanics, there is a panel of project members who participated in the Adopt and Spread program with us today, plus guests. They will be ready to answer questions. So put your questions in the chat box, and the host will make sure that the question is asked and then answered, hopefully. So be ready then. Be interested, be enthralled, and be inspired by what we have today. Diolch yn fawr iawn.
Welcome everyone to this session. The Adopt and Spread programme is a groundbreaking programme invented here in Wales. It brings together professional networks from across the whole of the healthcare economy to share innovations that were derived from our very own Bevan Exemplar programme. These achievements are very impressive, given the fact that we've endured a period of COVID, high levels of stress, and redeployment of staff. So the gains that have been made by each of the programmes you'll see today are truly impressive. You'll see overall 13 Bevan exemplar innovations, over 40 active adoption sites, involving 150 people supporting each other to improve performance. This is something quite exceptional and quite inspirational. The Bevan Commission would like to applaud all of our exemplars and all of the members of the Adopt and Spread programme. Please remember to do support Bevan, do tweet and message during the day, and share your best practice, because this is the true heart of what we do at the Bevan Commission. Thank you and enjoy your day. I'll hand over to your host.
Good afternoon and welcome to this session on ambulatory trauma care. My name is Dougie Russell. Pleased to meet you. I'm a an orthopaedic surgeon in Swansea in South Wales. I'm a hand surgeon, so ambulatory trauma care is very close to my own heart, and it's something we're trying to develop here. So I'm very pleased to be able to chair this session. I also chair the Welsh Orthopaedic Board, and this is something that we've had presented there, and it's to be encouraged and spread, we hope, around Wales. I'd like to welcome Ollie Blocker and ask you to introduce yourself, Ollie.
Thanks, Dougie. So my name's Oliver Blocker. I'm an orthopaedic surgeon in North Wales. I have been involved with the Bevan Commission for the past few years as an exemplar, and now that I'm a consultant, I'm very pleased to be able to adopt and spread my own work. On the back of this, I'm the clinical lead for same-day emergency care, which is very intimately aligned and close to what I do with the trauma ambulatory care across the whole of North Wales, and that covers medicine, general surgery, and trauma and orthopaedics. I would like to think that my expertise from trauma and orthopaedics can be applied across all specialties, and I really enjoy working closely with all my colleagues from different specialties to collaborate on this work.
Excellent, thanks, Ollie. I think we'll all be familiar with the fact that hospital beds are at a premium, particularly have been during COVID. Anything that keeps patients in their own home when they don't need to be in hospital is a great thing. I think there's a lot of positivity about this model of ambulatory trauma care. Just to remind you that if you do have questions, please put them in the chat box. We'll pick those up and I'll relay them to Ollie as we go along. But before we move on to the next stage, we'd like to show a short video about the service.
Hello, my name's Oliver Blocker and I'm the lead clinician for same-day emergency care in Betsy Cadwaladr University Health Board. I'm here at Ysbyty Gwynedd in our same-day emergency care unit. Here in our same-day emergency care unit, we are treating ambulatory patients. An ambulatory patient is a patient who's safe to go home and sleep in their own bed, but still requires hospital treatment. In this special unit, on the hospital front door, we can provide this inpatient care, which people can come to for 1 day or 2 or 3 days until their treatment is finished. And this avoids inpatient hospital admissions. In this collaborative workspace, where all specialties can cooperate and work together, we are able to provide the diagnostics and decision making to allow people to be treated but not admitted to hospital. And the aim of this is to happen on the same day. We're able to provide therapies, wide-awake local anaesthetic, no tourniquet procedures, and we have the space and capacity to treat people as part of the general medical intake, the trauma and orthopaedic intake, and provide decisions and diagnostics for the general surgical intake. So although I think this patient who has a stable, non-complicated injury could be treated well in a walker boot, they could go home and we could do a virtual fracture clinic follow-up to make sure that they've recovered from their ankle fracture. We can do a electronic discharge summary to send to the GP, and I'll dictate a letter which can go to the patient to give them all the information they need on their expected recovery, rehabilitation, and any SOS return they might need if they have any problems, and they can call us here in the unit. Hi, Mrs. Hamilton Crossley.
Yeah. Perfect day.
My name's Oliver Blocker. I'm one of the orthopaedic consultants. You've broken your wrist. It's called the radius bone, and it's just next to your wrist. This is a very common injury. It's in a perfectly acceptable position with just treatment in that plaster. Yeah.
So I can just do 4 weeks.
Exactly. It's a stable, uncomplicated injury. You only need 4 weeks in the plaster. We'll get you back to our plastering where they can remove the plaster. I'll give you some information on self-directed physiotherapy. You don't actually need to see an orthopaedic surgeon again. What we do need to do is, because you're over 50 years old, this injury can be a sign of osteoporosis. So we do need to put you in touch with our osteoporosis services. I'll do your discharge summary now. Do you need any painkillers?
No.
Fine. Good. So we'll give you some information and exercises, and you should get better by yourself. And you should have a pain-free functioning wrist.
Thanks, Ollie. So I'll kick off with a question. So from the view of the patient, can you describe how the service is currently running in Bangor?
Yeah, so in Bangor, we've got our same-day emergency care unit, which is similar in principle to a unit we have in Central, and we're developing in our East Hospital in Wrexham. We have TNO, general medicine, and general surgery doing what would be their surgical admissions unit. So if you're a patient who doesn't have major trauma, who doesn't have silver trauma, and has an isolated, uncomplicated injury, the intention is that during office hours, Monday to Friday, you can come from the initial front door presentation. So everyone has seen a clinician first, either a GP in the community or a nurse practitioner in minor injuries unit or an emergency department doctor, to come to the same day emergency care unit to have the rest of your treatment completed, which would be making sure that your plaster is okay. If you need scheduled surgery, because a very important part of this is having a scheduled trauma operation, so we're not impacting on our hot trauma list. You can have that scheduled, or you can have a fracture clinic appointment scheduled, or any virtual or non-traditional fracture clinic based follow-up, like that lady there who's over 65 and has a distal radius fracture and can come back straight to the plastering to have her plaster removed and self-directed physiotherapy. So that's the service that we provide, and we support not only our co-located emergency department, but also the minor injuries units that we have spread across their very large geographic area in North Wales. And these run from the Llandudno unit all the way out to Holyhead and down past Porthmadog to the Dolgellai area. So we cover a huge area, and we support our minor injury nurse practitioner units as much as we can during the hours that we're open to treat all isolated, non-complicated injuries as much towards the front door as possible, to avoid admission, like we said, and also to try and avoid unnecessary fracture clinic follow-up and or travel, because a lot of our patients take really big trips to come and see us. So that's the service we've got set up and are continuing to set up in a robust and reliable way, with the aim of making it, office hours 7 days a week. Right now, as I said, we're on a Monday to Friday situation, but as with all these things, it's a development in progress.
Great, thanks. Can you just clarify what you mean by silver trauma?
So yeah, silver trauma is when older people have an injury that maybe in a younger person might not be considered life or necessarily limb threatening, but obviously in an older person who has less physiological reserve, they can have much more significant consequences from the same injury that a less than 50-year-old person might walk out of hospital with, and that being able to identify these patients who are frail and have the social issues that do go along with what might seem like a relatively minor injury, it's really important to identify those so we can get those, usually the therapy and the community resources to make that patient safe, sooner rather than later, as opposed to just putting everything through our trauma ambulatory care unit in our SDEC. That notion of the triage and recognizing the frail people is really important in that step down. Like I said, we've got, it's pretty clear what's major trauma, but then that silver trauma is really important as well. And then excluding those complicated isolated injuries, things like where people might have compartment syndrome or neurovascular damage. Again, we don't want that going through our SDEC. That's for our acute on-call team. But then as you quite quickly filter down, you've got your isolated, uncomplicated injuries that we can treat very well in SDEC. So that's part of the triage process that is integral to all same-day emergency care work. So yeah, that's silver trauma, and I think that's something that a lot of units are looking at. But our emergency department are really hot on. So that's something we promote as part of this setup.
Great, thank you very much. And perhaps you could describe what used to happen to people coming into the unit prior to this project.
Yeah, so we followed a very traditional trauma and orthopaedic setup for our unscheduled care, which was we had an orthopaedic on call, surgeon during the week, and a trauma list, and we had fracture clinic. And you came to the front door, and you were either admitted to hospital or you were sent away to fracture clinic. And that fracture clinic included patients who had the traditional simple 6 injuries like buccal fractures, Boxer's fractures, and pediatric clavicle fractures, and also query fractures, patients who may have a soft tissue injury. And again, all these patients came from this wide area from our nurse practitioner-led minor injuries units. And, we ran a lot of fracture clinics that were very busy, and we had a pretty reasonable wait for a fracture clinic. The average would be sort of up to 2 weeks, especially in busy times. As a holiday destination, we really have peaks and troughs with our trauma demand. So that was the setup before this. And that was running up until the start of COVID.
Right, okay, thank you very much. So perhaps you could tell us a little bit about what it took to actually establish the service, who was involved and how long it took? So the first thing that was involved was the COVID-19 virus. So as a result of COVID-19, I'm as a consultant, I had no experience of life as a consultant pre-COVID. So I only know what's happened since COVID, which I guess kind of puts me in a fairly unique position. We, as part of our first response, according to the BOAST and the specialty guidelines, we created a role of a front door consultant, which we did during our what was our elective activity. And we had a bleep, the 997 bleep, which is now become fairly famous in the department. And the consultant would hold that for office hours, 8 till 4 or 5, and be the first point of contact for everything musculoskeletal. So no patient could be admitted without talking to the 997 bleep, and no patient could have a fracture clinic appointment without talking to the 997 bleep. And our emergency department could call that number, our junior doctors could call that number, and our minor injury units could call that number. And this support, this T&O support consultant, made a huge difference to our emergency department wait times and also our fracture clinic numbers, because when you've got that consultant delivered service for everything at the front door, you get your decisions made straight away, and lots of people could be treated expectantly as per the guidelines suggested, and that's really what we've been trying to sustain with the SDEC and the TACU work to now. We had that bleep right from the start, from March, the end of March, and we opened the SDEC in August. So we were doing a lot of the TACU SDEC work else just at the front door through this bleep and this contact, which we've then been able to sort of establish and sustain with the SDEC unit. But right now, as everyone tries to restart elective, it's this balance between the scheduled and the unscheduled care, and the fulfillment of the service that we provide as a consultant group, which is in a state of flux. So better lucky than good. We got it right first time with our response and our interpretation of that response, which we've managed to sustain, and it's led to SDEC. It's helped develop SDEC because with all these front door ambulatory emergency care, trauma ambulatory care, the biggest impact factor is that consultant being there to deliver and make decisions. And like with a lot of units, when they put in their response that was sort of 24/7 or even extended hours, it's now how you sort of draw back from that and still bring that decision on the same day. We were talking before this about virtual fracture clinic. That's a tool that we're going to bring in and use to provide the same day level of service, if you count same day as within 24 hours, which I think is a pretty reasonable compromise to providing this very high standard of care. So first was COVID, then was the work that I brought with me, because I was bringing my work with me anyway, and it's something that I'm very enthusiastic and passionate about. And then we
you know, I didn't come up with the idea of the 997. It was one of my colleagues, and it's all worked, and now it's worked. How do we keep it going? So that's, yeah.
Great, thanks. I think it's fair to say that you were keen to do this sort of work pre-COVID.
Yeah,
so that sort of work was going on, wasn't it? But COVID really was the enabler in many ways.
It's interesting. I remember at the start of COVID when I'd shared a lot of my work and the work that I did in Cardiff with the trauma ambulatory care, which takes the ambulatory emergency care network, and which is part of, or SDEC, same day emergency care, is part of that. And I remember looking at the specialty guidelines coming out, and I called up the guys who wrote those, and I said, "Did you get my email about that stuff? Did you read that?" And it's like, "Well, no, I don't think so." But you know, it's all the same principles, and it was so pleasing to see that these ideas that had come from ambulatory emergency care, my ideas, the problems that we tried to solve in Cardiff, the work from the Bevan Commission, GERFT as well, the Getting It Right First Time project. It's so pleasing to see all these good ideas that people are having at the same time come together, and COVID was the opportunity to put these in at pace and scale. And I mean, I'd still be doing the work that I'm doing, but I wouldn't be as far ahead as I am now. I mean, the idea that we've within 6 months had a dedicated unit opened and staffed and seeing patients how we wanted to do it. You know, six months for that change in the NHS, that's unbelievably fast, and it wouldn't have happened without COVID. So
great. Yeah, I think it's one of these silver linings we've had from the COVID pandemic, isn't it? So yeah, great. Can you tell us a little bit about the type of patients that come into the service, both for orthopaedics, but I'm also interested in the other specialties, because my experience has only been through the orthopaedic field. Yeah,
so with all this, it all comes down to the same principles, which is from it's all ambulatory, and the idea, the simple definition of an ambulatory patient is a patient who's safe to sleep in their own bed. They're ill, they've got an injury, they need hospital treatment, hospital level treatment, investigations, treatment management, but they don't need to be an inpatient. And so you don't need to admit people, and these patients can be in the community but come back to have their treatment. So the most obvious patient of ours is a patient who has an injury, like we've talked about, hand and wrist trauma. They have a wrist fracture. I mean, one of the things we also did was put in a wrist fracture pathway, which we did right at the same time, which has been a really great thing to do to focus people's minds on this very common injury. And so you've got this wrist fracture, you've followed the pathway, we've done what we need to do at the front door, and an operation is the right thing to do, because this fracture is probably not going to work unless we do an operation. So instead of being admitted to wait on a hot trauma list, we can then schedule the surgery for the patient at a convenient time. They can come to the same day emergency care unit on the day of their surgery. They can go to theatre from the same day emergency care unit, which fits very nicely with the inpatient ward trying to clear the beds in the morning and then having those beds available later on in the day. And by the time they finish their surgery, say if we can get it done under regional anaesthesia, maybe they can come back to the same day emergency care unit and go home from there, or they have a very short stay in an inpatient bed if they have a general anaesthetic and then go home. And this works with the patient flow in the hospital. It works with the same day emergency care unit. We're doing these hybrid combinations to make the best use of the resources we've got. And I think really importantly for these patients, they are not in an inpatient bed and not impacting on the people who need to be in inpatient beds. And I'm thinking, for a trauma and orthopaedic surgeon, the frail elderly femur patients, the femur fracture patients. Those patients need to be in a bed. They need their operation promptly. They don't need anything to mess that up. For medicine, same thing applies. If we use the news score, that's part of the criteria for seeing whether someone's safe, as well as the clinical decision, is this patient safe to sleep in their own bed? So a medical patient who's safe to sleep in their own bed, they've got a normal news score, they're not frail, and they're not having one of the predefined serious things like having a heart attack, which you may be walking and may have normal observations. And they come to the same day emergency care unit, where we try and work them up, do any decisions, diagnostics, let them go home. They can come back for therapies. We've got our therapies unit there to give IV medication, which our endocrine colleagues use a lot of. And we try and get people who say need blood tests to go home and then come back to their SDEC where they can get their blood test done. For general surgery, it's a little trickier because we lost our very well-functioning surgical admissions unit, which we've now relocated to our SDEC. So we're doing a lot in one quite small unit. And we really do want to develop our SDEC for general surgery, but each specialty is slightly different. At the moment, we're doing a surgical admissions unit in our SDEC, and hopefully as we get more space back on the wards or have a bit more in hospital real estate, we'll be able to focus more for our general surgery colleagues and even put more of our medical inpatient work through the SDEC. With all these things, space is a real issue. We had the physical space there, we just weren't using it. Now we're using it, obviously quite quickly. If we do everything we want to do, it's not going to be enough space, but we're actually being forced to work within the space we've got very efficiently and in a very clever fashion, so that we can use this for what we want to do. So that's how it works. The medicine and the trauma and orthopaedics are the traditional ambulatory patients. General surgery is a little bit different, but then it's slightly different for all the specialties. But we're continuing to work, and it's great being able to work on it whilst we're doing it, as opposed to plan it and then it not work.
Okay, great, thanks. And I'm interested to talk a little bit about regional anaesthetic, which you just mentioned, particularly coming back to trauma and orthopaedics. So, for example, acute meniscal repair in a knee or an ankle fracture, are these things you're doing under regional anaesthetic at the moment?
Yeah, we really want to push regional anaesthesia as much as possible. We decided for our same-day emergency care unit, if people are having, if they're having wide-awake local anaesthetic, no tourniquet surgery, we're trying to make the appropriate space to do more of that in the unit. For people who are having scheduled trauma surgery, they come in, and hopefully we can do them under regional anaesthesia. And if we've got the capacity and the nursing staff in the unit, then we can bring these people to the unit to discharge them from the unit to make sure we really have same-day scheduled trauma care. General anaesthesia, at the moment, we don't routinely bring patients back, so they still need to be in an inpatient bed. And again, a lot of these things are happening at the same time. We're trying to develop our regional anaesthesia work with block rooms and really promoting regional anaesthesia for our scheduled trauma. So that is part of this development from the inpatient side of it. But we're trying to be as flexible as possible to facilitate patients having regional anaesthesia, because if we can, in the ideal situation, if a patient come into the same day emergency care unit, have their scheduled procedure under regional anaesthesia, come back and be discharged from the same day emergency care unit, then that's job done.
Absolutely agree. Yeah, I think it's the way forward, isn't it? Particularly with the COVID sort of surges, general anaesthesia, aerosol generating procedures and things. Our experience has been that the blocks have been very much safer, and the whole pathway just becomes a lot easier for everyone involved, really. And I think that one of the other positives that's come out of COVID is our anaesthetic colleagues who are interested in regional anaesthesia have started to really sort of push the boat a little bit in terms of the indications and the types of procedures we can perform under regional blocks, which I think, again, is something we'll take forward once hopefully the COVID thing settles down.
Yeah, and like you said, that's one of the benefits of COVID with the aerosol generating and the issues surrounding COVID and with repeat waves, which you're going to have. We've just come out of one ourselves up in Bangor because we're always on a bit of a delay with everyone else, but that's just part of the distance. Yeah, the default for upper limb surgery would be regional anaesthesia and same day case surgery, and that's the vision, that's the aim, and there's no reason not to push for that being the default and then work backwards from there, as opposed to it being, oh well, if we can do it, we'll do it this way. It's like, no, push for that standard of care which fits with everything we're doing and the world we are living in now, and if you work towards that and and make that new paradigm of care, then and I think we're going to be winning, because, like you say, with COVID, at the moment it keeps on coming back. Our own experience, we tried to restart elective, it didn't work as we wanted it to because of COVID impacts. So it's a good position to come from, I think.
Yep, absolutely. No, agree. Yeah, perfect. So you work closely with the innovation improvement team during this project. Can you explain what sort of role they had and how important that is?
Yeah, so our research and innovation department, I was working and linked with before I actually even started in my post. And unfortunately, my colleague can't be with me today, but Melissa Vanderbilt, who's our innovation project lead, and the rest of the team, Lynn and Mel and everyone there, they've I couldn't work without them. I mean, I spend as much time, or nearly as much time, certainly during COVID, whilst I was setting this up, with the R&I department and in their offices as I did in the trauma and orthopaedic department, to have their support and their their influence behind the project really, I think, has made a huge difference. And obviously we can't not mention the Bevan Commission, because we would be working all together. So me, Melissa, Joe or Rupert or Sean from the Bevan Commission, we'd be in the same office on a Zoom, or this was pre-Teams, so on a Zoom, working through processes and pathways and working out how to do this project. And yeah, it couldn't happen without them, and that's why I'm still working really closely with them. There's been funding for this, which has helped. I mean, we'd be doing it anyway, but it is much easier when you've got a bit of financial influence behind it. And as I think, as being associated with the Bevan Commission and Research and Innovation has helped me lead on this project and given me the contacts and the networking, for example, with the National Virtual Fracture Clinic group and the National Same-Day Emergency Care group, to be involved with those. And then everything ties in, and the same people who are trying to promote change in the NHS in Wales and elsewhere are all with you, and their advice and guidance to support you through this, because it's a long journey. It takes, as the introduction said, persistence is a big part of it, and you really need people behind you to keep you going when you're doing these long-term projects. Because even though we opened the unit in 6 months, to keep it going is going to be, that's like years. So yeah.
Yeah, great, thanks. And on that one, change and some people's resistance to change, how did you bring the staff along this project? Do you have any problems, or was everyone as enthusiastic as you? No,
not everyone's enthusiastic. There's always going to be resistance to change. Part of this, I think there's two things. Part of it is inherent with the way that unscheduled care and trauma has been structured, and that traditional model. And it's very difficult to break out of a traditional established model and do something different, because the whole system and the whole process is set up to that traditional model. So you have to change everything from top to bottom in small incremental changes that don't destabilize the whole project. Again, COVID has helped with this by not letting us flick straight back to normal, and that was never going to happen, but it's helped by keeping people available to do this as we work out what is the right way forward. The next thing, this is the people, because we can't do anything without nurses, and we don't have enough nurses, and we've had huge impact on. There's been a huge impact on the nursing levels, which were an issue in North Wales anyway, and everywhere I think is coming the same thing. And then also people's job plans, which relates to how the unscheduled scheduled care is serviced. People's traditional job plans have been established, not incorporating how we want to work now. And we do need to reconfigure how our jobs function in the new normal. We can't do what we need to do with the changes we've made as a result of COVID on the basis of how things were structured and arranged pre-COVID. And that needs to be appreciated, because people have lives that are based around how their jobs were structured, and it needs to be renegotiated. And I think we need to be very honest as we move forward with what people are interested in and how they can provide the best value for the organization. Trauma is not a toll or a service or an ordeal. It's the cornerstone of much of what we do. We're trauma and orthopedic surgeons for a reason, and people have different views on it. And I think people need to work out what they're interested in, and maybe recheck and change what they're doing, and maybe do more of something else and less of another thing, and maybe run a slightly tighter ship with the numbers of people. I mean, we've got nearly as many consultants on our trauma rota as a major trauma center. We're a serious trauma unit, but we're not a major trauma center, and we have to work out how best to reorganize ourselves and replan our workforce so that the consultants can deliver the level of service that we want to deliver. And that is a huge challenge. And it does need very strong clinical leadership from the organization about, this is what we want to do, this is what we're committed to, and we want to deliver this, and we need your help to do this. And just be very honest with people and work out what people want to do. That's my opinion. We'll see how it pans out. I'll let you know.
Please do, yeah. But I think from my personal experience as well, that anyone who's been involved with this sort of service and all the positives it brings for everyone involved, but particularly the patients, that actually it's something we wouldn't want to lose going forward. So I absolutely agree with you. We need to make sure this is the new normal for us.
Yeah, and that new normal is, I think, is difficult for a lot of people to get their heads round. We're not going back to how we were, and that is a huge change, which lots of people may take a long time to accept. And like you say, that at the end of the day, it's the patient at the front door, and it's the service we provide. And if you're really involved with this and you can see the benefit and you understand the patient benefit, I find it very hard how you wouldn't want to be involved. And if you don't want to be involved, then please work out how you can be involved elsewhere to provide the highest standard of patient care, which might not be trauma.
Okay, great, thanks. An interesting question from Jenna, actually, saying let's take this one step further, installing transportable X-ray machines into ambulances and taking imaging to the patients. Lots of radiation governance issues, but low-dose examinations such as wrists, hands and ankles. Could this be possible? Any thoughts on that?
Yeah, that's an interesting concept. We were that takes it. That's definitely pushing the boundary. I really like that question. For example, in Bangor, we have a mini C-arm portable X-ray machine in the emergency department, which we want to try and put into our same-day emergency care unit, maybe either for more rapid diagnostics, or probably most likely for doing some minor metalwork procedures in the unit as per wide awake local anaesthetic no tourniquet type procedures. Now, like you say, the radiation regulations and everything makes it very difficult. That's a sort of next level stuff that we could get to. It does fit in with, like, how can we take things, especially with our distance, how can we take things to the patient, which is something we want to work on. And I guess it kind of comes from the empowerment of those people at the front door, which may be 50 miles away from our hospital. And what can we do to make it better for them and allow them to make decisions quickly and provide treatment, so people don't necessarily have to have the physical journey and the experience. Going back to X-ray, for example, we've got a minor injury unit that runs X-ray Wednesday to Friday. So you might come in with a musculoskeletal injury that needs an X-ray on Monday. It's like, well, okay, how do we coordinate you coming back on a Wednesday? So these challenges are universal, but the principle of getting getting the right tools to the right people and working out how you can use that within the structure of what they've got to empower them to be able to make decisions and keep that treatment out the front door to stop the previous default of like, well, I haven't got x-ray today, so I'll book your fracturing appointment in 2 weeks' time. And you travel 100-mile round trip. It's, you know, it's a no-brainer, but the difficulties of putting those things in place, those challenges are intense because there's so many different things you've got to think about.
Okay,
yeah, great question. Thanks.
Yeah, no, good one. And perhaps a halfway house would be X-ray machines in GP clusters or wherever, particularly in very large geographical areas that you cover, because we can all now remotely monitor X-rays, can't we? So
yes,
that might be our answer. Yeah,
it's
okay.
And that's you know, I'm sitting here with my work laptop. I'm not in work, and I can see X-rays. You know, we don't have to do WhatsApp or any of the other things. Like, well, if you've got the laptop and you've got the token, you can log in and look at it. So, yeah,
brilliant. Okay, fantastic. I'm going to draw this session just to a close. We've got a short video now looking at some of the other projects that are showcasing. So after that, we'll then come back and have some more questions, perhaps about how we then spread the good work you've done. Brilliant. Thanks, Mike. Cheers. Okay, welcome back. So in this next session, we're just going to explore about how we might spread the good work. We just had another question in the chat. We talked about maintaining the momentum, embedding this way of working. How has measurement of the impact or the improvements resulting from the changes been used to support this, recognizing that measurement is often a challenge?
Well, firstly, thank you so much for recognizing that measurement is often a challenge. It's a good thing. I like spending my evenings when I get the chance sitting in front of spreadsheets and crunching numbers, because yeah, bringing it all together is very difficult. Firstly, because I'm the lead for same-day emergency care, I've pretty much incorporated the trauma ambulatory care into same-day emergency care. But it does mean that I'm also working on medicine, general surgery, and T&O. So from the initial COVID response, we saw our 4-hour A&E times drop dramatically for musculoskeletal. And that was probably one of the biggest impacts that we can directly relate to what we were doing as a result of our front door ambulatory trauma care changes. Later on, once our SDEC was opened, we used the definitions and the metrics put out by the same-day emergency care group, which was work out how many people and the patients and the percentage of your unscheduled take that's ambulatory that you're putting through SDEC, and then what's the volume and percentage of that you're sending home that actually are ambulatory, and you need to keep that really high. And then if you are admitting people, how long do they stay? But you know, that's a secondary thing. I think the first two questions are most important. So from our SDEC trauma ambulatory work, we looked at a 3-month period when we were working 5 days a week, and we saw 44% of our unscheduled take through SDEC, which is really good, because it should be, the benchmark figure was a third. You know, whether that's an accurate reflection depending on your specialty or your opinion differs, but we were doing better than we should have done. Our percentage of patients that we didn't admit was 80%. The ideal would it be more than 90, but maybe that was skewed by using our scheduled trauma work coming through the same day emergency care, where, as we talked about at the start, some people would be admitted because of the type of surgery they had. You know, our length of stay from our SDEC was less than a day, so we're still, you know, keeping the hospital stay short. Now we pulled figures for medicine and general surgery, but they're very different. Like we talked about with medicine, it's a different volume. It's, you know, magnitudes more patients, and general surgery, it's a different setup because of the constraints from COVID. But that measurement, I think, is really important because it relates to the national program and what the government are asking for us to do and how to measure. It's like, okay, we've got a starting point, this is what we're doing, and then we can have a baseline figure to compare to. And that's really important because that relates to how funding comes for this work. Funding is a challenge. There is enough money coming in, but it's how we use that funding, and that relates to how people work. We've talked about how consultants work, but it's also nurses, therapists, everyone else. So that's the data we've got, and we now need to do that for all the other specialties and all the other sites we're doing SDEC on as we develop it. And it's really important to have that figure. I mean, they're fairly simple questions, but they're pretty tough to get out because it relates to how the hospital's systems and structures are in. But we've got a start point, and we can build on that.
Great, thanks. And can I just ask a little bit about follow-up? Certainly during COVID, we've been sort of using absorbable sutures and patient removable casts, just saying, look, virtual physio, we don't want to see you again. Is that something else you've done and measured the reduction in outpatient appointments needed?
So we've that is something we've done. We really wanted to promote soft casts, removable casts, and keep everything as standard. Use back slabs, show patients how to cut them off. Use walker boots, try and keep everything as simple and patient removable in case they don't need to come back. We looked at our numbers coming into fracture clinic, but we weren't able to relate that to those specific measures. We only know general numbers that come in, which does vary according to what's going on, and also with all the other impacts that, you know, we don't have the control over the fracture clinic numbers that we really want to see. What we were talking about before was the virtual fracture clinic. That's a tool that we want to put in as part of our same-day emergency care for ambulatory trauma to try and give us more control over what's going on. We've put in already the Simple 6 as part of the Scottish fracture clinic redesign. I mean, that's a fairly straightforward tool to put in, where that's a direct discharge. But again, without the coordination of all the clinical systems to then know, you know, the metric for that is what is your SOS return rate, because you want to make sure that the people you're discharging aren't coming back. And I've just seen that Joe's put up on the question about Symphony and SDEC. Yes, it does have a module. We've only just installed Symphony in all our minor injuries units, and we haven't installed Symphony in our SDEC unit yet. So, I mean, ask me in 2 years' time when we're all on Symphony or whatever it is. But yeah, this interface between running a paper CAS card-based system to go to an electronic system and using a self-made database to run it makes your brain seep out of your ears, because you know what you want to do, but the complexities of the IT systems to get there, again, that takes a long time. And, you know, as far as Symphony, I mean, great. Symphony is a tool that we could use all at the front door, but then suddenly you'd be asking the Symphony guys to say, well, instead of training, 1,000 people in stages, how about you train 15,000 people? And it just can't work. We are lucky in North Wales. In Bangor, we've got a really good patient administration system, which gives us a lot of our data. and we do have Symphony, which is really good. But yeah, the interoperability of all that is a development thing. I see another question. Sorry, Doug, it's just popped up on my screen about the feedback from trainees. That's a really good question. It's difficult. I think it relates to that idea about the traditional models. The traditional model of, if we're not training the trainees, if we're delivering the service at the front door, what are they for? They should be in fracture clinic seeing the patients. It's like you've kind of got to swing around to, well, if we have this new model of care that we're delivering standardized, non-variable care for these stable, non-complex injuries in this model, and you see us delivering this is good, this is showing you best practice, and you can learn from a best practice, as opposed to learning from your mistakes in a fracture clinic. That's the principle that I would go for. But again, that's part of changing mindsets from traditional models. Trainees in Bangor, again, we're in a unique situation. There's a gateway hospital with lots of trainees who are very new to the National Health Service. I think it's an ideal opportunity to show them a way that things can be done that is what I think the best practice that delivers the best consultant delivered service. But that's not a view that's universally shared. The trainees do, I think, appreciate being in the same day emergency care unit with a consultant. I think anytime you've got that team working at the front door delivering care, I think that's an ideal training opportunity. So that's the answer to that. But we'll see what happens from the trainee surveys, which are still ongoing. Oh yeah, building the time into deliver training. Well, time, building everything in, again, it's how we're working our new normal models, and training is a very big part of that, because that's again the shift from consultant-led service to consultant-delivered service, and that's a whole nother debatable point. I'm very much on the side of consultant-delivered service, and the training comes in the delivery with the trainee seeing the best practice and knowing the right way of doing things, as opposed to learning from mistakes or maybe ways that aren't so efficient and good. But that's a personal view. Okay, so I see that Dougie's left, so I'm going to take over. Let's look at the questions. So we've talked about that. Would anyone who's in the session like to ask a question? Otherwise, I will go on and talk more about what we're doing across North Wales. Okay, so what's next for Bangor? I've mentioned some of this before, but what we're doing now with ESTEC, and this comes from my role as the same-day emergency care lead across North Wales, is we're working on getting the same-day unit in Bangor working 7 days a week. Now, we've just run a test run of the last bank holiday with opening on a bank holiday, and we are still looking at the impact of that, but again, it was only 1 day. What we really want to do is get the systems and processes for medicine cemented during the week. We're pretty clear on what we need to do for trauma and orthopaedics, and now it's getting medicine up to speed so we can take both specialties and run it over the weekend to give a real 7-day service and see what the impact of that service has on our patient flow, especially our admissions for medicine during the week. Then, I say then, these things are all happening at the same time. With our central hospital, Ysbyty Gan Clwyd, they've actually been running same-day emergency care for medicine, general surgery firstly, and then medicine, run by my colleague Richard Morgan, who's the general surgical lead in central, as part of their emergency quadrant, which is a fantastic co-location of the emergency department, same-day emergency care unit, surgical assessment unit, and an ambulatory medical unit. And I've visited that, and it's such a great setup. You can just walk across from one part to the other, so you can work out how to treat patients, especially ambulatory patients, in that one unit. And so they're doing the same principles. They've got a very different setup from us, where we've got our unit sort of co-located, but we're still trying to work out, we're not located with an ambulatory medical or a medical assessment unit and a surgical assessment unit. Like I said, we're trying to do one thing in one place, and then the medical assessment unit keeps changing wards. In Wrexham, again, it's our general surgical colleagues who are taking the lead on that. They're working on setting up a same-day emergency care unit for general surgery, co-located with their SAU. And they're starting to develop that now. So it's really good that all three sites are adopting and spreading this work, even if it's in a different specialty. This is not something that I could have foreseen when I was bringing this work up. I thought I'd be looking at trauma ambulatory care units, but it's changed, and it's really good to be helping and collaborating with other specialties to work out what we need to do to get it in our three acute sites. So that's what we're working on now.
Sorry, my connection dropped out somehow. I don't quite know how that happened. It's the joys of online platforms. So I'm back, so sorry to desert you, but clearly we're still speaking, which is great. Yeah. As it dropped out, I think we talked a little bit about training, and I was just about to come in because certainly our experience has been fantastic for the trainees. Because during COVID, a lot of them were redeployed to wards, weren't they? They were doing sort of general ward work and things, not getting any operating. And then now 3 full days a week in our day unit, we've got combined lists with the plastic surgeons doing upper limb trauma. And the trainees are getting fantastic training. And at the same time, the anaesthetic trainees are getting brilliant training in regional blocks. So that whole thing in a really difficult training period has been a little bit of a silver lining as well.
Yeah. So I came onto that. I was talking. It's been a bit of a mixed bag for the actual SDEC, and I was mentioning how I think it's part of the consultant delivery of the new sort of standard of service allows the trainees to see the delivery, and then they can copy that and take it on, as opposed to being maybe led or less supervised in the fracture clinic, being a bit more reactive and maybe learning from their mistakes maybe. I'm firmly into this is how it should be done. This is the right way. Please watch me and take this on board. Our actual trainees, I know that our unit was very high up on the preferred units from the feedback, because we were still doing a lot of the scheduled operating. So I think our West Midlands trainees and our Welsh trainees were really enthusiastic about what we were doing in Bangor. Because of the work that we've done with our scheduled trauma, less so for the SDEC unit, because I think it was more put in with the front door, which they were pulled off of for the ward stuff, like we talked about, and being redeployed. So it's been a bit mixed, but I know we'd had really good reports for the amount of operating that people were doing. I guess in similar fashion, we don't have the day unit, but we've got our scheduled trauma lists, which we kept going and worked really well for training, so people were getting that training. But yeah, it's the balance. Surgical trainees just want to operate, but they've got to, there's other things that that are not necessarily operating. They're really important to pick up on. So
yeah, agreed. And actually, our registrars have a role in the virtual fracture clinics as well, which if this is a new way of working, they're going to have to get used to it, I guess. So
and that's what when we start building in the virtual fracture clinic. I think virtual fracture clinics are a fantastic way, because you're with the consultant, you're with the therapist, you're seeing how to do things and knowing what to do right way first time, and getting from people's experience and reducing any variability of care. Because I think that having a standardized approach, gives you the bandwidth to cope with the more complex stuff, which will come.
Great. Okay. Thanks. And have you got to the stage where if you see, say, a wrist fracture in A&E that clearly needs fixing, they're just then remotely booked onto an operating list?
Yeah, so like I mentioned, we put in this distal radius fracture pathway, which really took the BOAST guidelines and the draft work further. I know this is a contentious issue, but we were really looking at, well, look, if you're over 65, the default's conservative management. And then if you're under 65 and it needs fixing, we don't want to be subjecting people to any unnecessary procedures. And then the third part was, if we can do a manipulation under appropriate anesthesia in the emergency department, is that enough to treat people conservatively? And we've just finished looking at all this results, and we made a big change. The compliance is not 100%, but there were cases where we've saved people going to theatre. We wanted to standardize things so that people could come back at 5 weeks. Between 4 and 5 weeks, we actually chose 5 weeks for most of our fractures, to have a plaster off and not need to be seen again. And the people who had an MUA to come back at a set time to see a surgeon, to say, okay, this is either working and you're going to continue, or you need an operation. And then the people who come into ED who definitely having an operation, you don't mess with them, put them in plaster, book them onto a scheduled trauma list. Yeah, and that's the ideal. The execution, obviously there's some hiccups with how we're working it. But yeah, I mean, we worked with our trauma coordinator. We did get it working. It's working. It's installed. The ED guys have taken it up, really enthusiastically. They've really driven it. In fact, quite often they know the pathway better than the orthopaedic surgeon. So that's fantastic, and hopefully we'll get everything towards that standard. So yeah, exactly. It all fits in. The lady who was in the video, she was actually seen in one of our minor injury units. So she's seen at the front door. It's like, okay, let's see what happens. She came, she had a proper plaster. It's like, okay, that's fine. That'll do. You're on the pathway. You're over 65, conservative management. You're coming back to SDEC for a plastering change. She doesn't need a fracturing appointment. She can come at her own convenience. And that's a game changer. I think that's a great experience for patients.
Yeah, no, I absolutely agree. And during COVID, of course, we wanted to reduce footfall in clinics and on hospital sites. So we got to the stage where, X-ray and A&E, virtual fracture clinic, booked straight onto an operating list. And it does take a little bit of change of mindset for the surgeons involved. I turned up yesterday afternoon to do 3 fractures that I'd never seen before, patients I'd never met before. But again, that's all about having senior involvement, isn't it? And I'm teaching trainees at the same time. So, and from a patient perspective, particularly with the distances involved around your area, then that's got to be the best way forward, isn't it?
Oh, it's we get people from past Dolgethli, and if they don't have to come back, they are delighted if they don't have to come back. And the ideal is actually the model that you're talking about of virtual fracture clinic or some virtual thing. It's like, we've seen your images, this is what we want to do, and we can use remote X-rays as well. People have mentioned that people can go get a check X-ray at at one of our peripheral hospitals, which is 25 miles as opposed to a 100-mile round trip, and then we can look at the X-rays in a virtual setup, and I'm really excited to be putting in this virtual model that works and is an actual model and a process to fit in with the same day emergency care stuff we're doing. So yeah, I think that's great. I think that's, like you say, it's difficult for some people to get their heads around that, but it's the way we're doing, because it's a better way of doing it.
Great, brilliant. Totally agree. Yeah. And what about the other units in BCU then, spreading the good practice? Yeah,
so whilst you're off, I was just talking about that. It's interesting that we've got and they've actually been doing same day emergency care in Glenclwyd in Central since 2018, but that's been led by the general surgeons. And again, it's our colleagues in Wrexham. It's the general surgeons leading the same day emergency care, which is interesting, because my experience is that actually general surgery is probably the most sort of opaque and most difficult specialty to put into same day emergency care, because the time frames are slightly different. It's a lot more clinical, hand on the tummy, looking at the patient. Whereas medicine, I think you can take a lot of stuff through pathways that are already there, and T&O like I say, if you've got an isolated, uncomplicated injury, you're an ambulatory patient through SDEC. That's how it goes. But the fact that the general surgeons are driving this and putting it forward, if they can get the general surgery right, then I think everything else will flow. And then it's working on the volume of patients for medicine, and then putting T&O into it, who are probably one of the most resistant specialties to change from the established traditional models to virtual and front door models. But people have had practice with COVID, so it's not like this is actually a new thing now over a year in. I mentioned layout. The space for how you do this is really important. We were, I was lucky to come to Bangor where they had the space sort of set up, but didn't know how to use it or the right way to use it. And SDEC has fit in nicely, and it's co-located to ED, but not necessarily to the other units. In Central, they've got an emergency quadrant where it's literally a square with a cross, and it's SAU, SDEC, AMU, ED. And you couldn't have a better setup for running ambulatory services for that. And Wrexham, again, they're trying to work on how to make space and taking our advice and trying to make sure they don't make any obvious mistakes in setting it up so that it works and is sustainable. I mean, the thing that is one of the hardest things is that when you set up an SDEC, it should really be set up as a ward. But then if you set it up as a ward and people put beds in it, then it can be bedded as a ward and not a same-day unit. So whatever you do, when you build it, put in treatment chairs and bolt them to the floor, and don't make the space so you can actually fit a bed in, so then it can't be bedded and you can keep it open. So it's all these things that bring together as a whole sort of system change and infrastructure change. And it's really interesting seeing how the different sites are using the space they've got in the ways, and then adapting their working patterns and models to it. So it's great, and the fact the organisation is fully behind it, I think that makes a huge difference. So yeah, that's what we're doing across North Wales.
That's brilliant, thank you. Unfortunately, I think we're going to have to bring this session to a close. We've run out of time. It's been a fantastic conversation. Thanks, Ollie, for your input. It's been tremendous, and keep up the good work.
Thanks.
I think it's really important. I think a lot of us recognise that it's the way forward, particularly from a patient's point of view. So thanks for your input today. It's been really, really helpful. Thanks to everyone for joining us. And do please keep in touch.
Yeah.
Thank you very much.
I'm going to go on to the table thing now, and hopefully that'll work. So if there is anyone who does want to continue the conversation, I'll be available after this. And I'll sit there for a bit. So if people want to talk about or raise any other questions, I'll do that. But yeah, no, thank you very much for hosting me and allowing me to talk about the stuff that is very close to me and I'm really enthusiastic about. So that's great. Thanks.
No, that's brilliant. Thank you very much.
Okay. Right, let's go. Leave.